right. If you're just joining us, please place your name, email, and agency in the chat box, and welcome.
Right, fuck.
Oh, there's no one.
Good morning. Just to remind everybody, if you're just joining us, please mute your microphone. We will get started just shortly once we allow everybody to get in. If you haven't done so already, please enter your name, email, and your affiliated agency in the chat box, please. All righty. I think we can get started. Looks like we're caught up on the room here. Looks like we have Dr. Toya, Sebastian joining us. I'll just give them about 30 seconds to join on. And again, good morning. If you are just joining us, welcome. We are privileged to have you here. If you would, please put your name, email, and agency in the chat box. And to let everybody know this is being recorded. It is being streamed on Facebook Live. So if you'd like to turn the camera off, please feel free to do so. All right. If someone, Colleen, if you don't mind just watching the room for me real quick, I'm letting in the last two people, and we'll get started. So to start things off, what I would like to do is I would like to administer a poll. And I'll give everyone 5 minutes to answer the questions. You should see it on your screen. 4 questions in total. Does everybody see the poll on the screen? Okay.
Yes.
Has anybody started taking the poll yet?
Yes.
All right. I know for whatever reason I don't see the stats yet, but if you just joined us, welcome. Thank you for joining us. If you would, please put your name, email, and agency in the chat box. We are currently running a poll right now. If you could answer the poll questions, we'd appreciate it.
Jonathan, Dr. Toya is reporting that the submit response button on the poll isn't working.
Okay. Let's
It
see.
did work for me.
It
Okay.
did?
Yes.
Okay.
John, I can actually see the results over here, so people are answering.
Okay. Excellent. Thank you. And I'll give it another couple more minutes. Once again, if you just joined us, welcome. When you have a minute, please put your name, email, and agency in the chat box. And please take a moment to answer our poll question just to get started. Just trying to gauge our audience, see where everybody is at when it comes to problem gambling behavior among veterans. I'll give everybody 1 more minute and then I'll end the poll. We are really excited today. We have 2 great speakers. I'm chomping at the bit to let Dr. Waite and Dr. Toya loose. So I'm going to end the poll here in about 10 seconds. Let me know if you need more time. Go ahead and just unmute yourself if you do. If not, I am going to close out the poll and we will get started. Welcome, everybody. We're excited to have you here today. This presentation is brought to you by the New York State Veteran Problem Gambling and Suicide Prevention Coalition. It's in collaboration with the New York Council on Problem Gambling and the community engagement and partnership coordinators of the VA across New York State. couple years ago, I had met Michelle and Jennifer of the Albany VA, and we discussed problem gambling among veterans and its correlation to suicide. And we decided to create a coalition specifically targeting the prevention of problem gambling and suicide. Today, you will learn about the correlation between problem gambling and suicide, also screening options available. But this coalition has now gone statewide. It was several regions throughout the state. We decided to combine forces, and we're going to be one statewide coalition with our regions represented during meetings through breakout sessions. Our main objectives is to raise the awareness of problem gambling among the veteran population, to increase screening among agencies that serve veterans, and to connect veterans to the services that they deserve, along with their family members. Without further ado, I would like to introduce our guest speakers. And our first one, Dr. Waite, I will have Jennifer Stiletto-Smith of the Albany VA. Go ahead and introduce Dr. Waite.
Thank you. Can you hear me?
Yes.
Okay, great. I'm going to read the bio from my phone because I've turned into my mother and I can't see very well on the computer when it's so small. So I apologize if you see me holding my phone. All right. So Dr. Les Waite is a military psychologist working at the Albany VA Medical Center in rainy Albany, New York. Dr. Waite has worked within the VA healthcare system for the past 10 years, treating veterans with chemical and behavioral addictive disorders in inpatient, residential, intensive outpatient, and outpatient environments. He previously worked in the National Gambling Treatment Program at the Stokes VA Medical Center in Cleveland, Ohio, where he treated veterans with gambling disorder in both residential and outpatient settings. He is a graduate fellow of the Disordered Gambling Treatment Supervision Fellowship, a program designed to educate clinicians on providing supervision to other professionals who treat people with gambling disorder. He is a member of the National Council on Problem Gambling, a certified international gambling counselor, and is a member of the New York Council on Problem Gambling. A veteran himself, Dr. Waite served for 11 years as an active guard reserve in the Ohio Air National Guard, graduated with honors from the U.S. Air Force Non-Commissioned Officer Academy, and was awarded the Air Force Commendation Medal for Meritorious Service. And I laughed because I had to ask him how to say that word. And right before we joined, I Googled, is that medal a big deal? And so what I wanted to say about that was it said that the achievement or service that is incontestably exceptional and of magnitude that clearly places the individual above their peers while serving in one of the assignments for which the medal has been designated. And I don't think truer words could ever be described for Dr. Waite. So I just wanted to mention that while I introduce him. So take it away, Dr. Waite.
Well, thank you, Jen. That was a very heartwarming introduction, as well as humorous. Good job on Meritorious, by the way.
I practiced.
I could tell you did. Good morning, everyone. Thanks for joining us on this Friday morning to talk about this very important topic, and a topic that's dear to all of our hearts as clinicians, I know. I'm going to start this morning by talking about everybody's favorite topic, statistics, and regarding prevalence, gambling disorder. I'm going to talk about the impact of gambling on military veterans, give you some ideas, and I'm going to talk about how addiction and suicidality are related, both chemical and behavioral addictions like gambling disorder. We're going to talk about screens, common screens that are out there, the different levels of screening, for example, and some of the most common tools that are out there. And I'll provide you with a link to OASAS's website. They have some approved screening tools for gambling disorder and assessment tools that they published on their website. I'll go ahead and give you that information as well. I'm going to talk very quickly about the existing treatment options for folks with gambling disorder in the Veterans Healthcare Administration, the VHA. And then hopefully our discussion this morning is going to provide some answers to the poll questions that we talked about at the beginning. And there'll be time for a brief Q&A afterwards. But by all means, I'm the kind of person that as I'm presenting, if you have a question, please by all means interrupt me. The only thing here, I think, with the virtual environment is I'm not going to be able to see your hand raised or the chat box. So if one of my colleagues could let me know that somebody has a question, I'd appreciate that. I'm happy to answer. So I'd like to start talk about statistics and prevalence. So a recent study from 2020, this is the boring part, it'll be over very quickly. There's been a 90% increase in the general population of adults who gamble. It's amazing, just in the past 2 decades. It's amazing. Lifetime problem gambling for the general population is at about 2 to 5% of adults in the US. They have a lifetime problem gambling issue. And about 10% of military veterans have a lifetime gambling issue. Let's see, and then that's problem gambling. When we talk about gambling disorder, which is the full-blown diagnosis, about 2% of the general population in the United States has that diagnosis, and about 3% currently of military veterans do. This was a study that was conducted in 2020 that came up with these results, and they were from colleagues of mine at the Gambling Treatment Program in Cleveland. So they're always at the forefront. If you want any of the current research being done, Case Western Reserve out of Cleveland and the Cleveland VA often collaborate on studies, and they're a vast storehouse of information when it comes to gambling disorder and military veterans. So let's take a look a little bit closer at what they found regarding the impact of gambling on military veterans and some of the reasons why the problem has a greater impact on veterans. Regarding risk factors, there are about 12 common risk factors for problem gambling, but some of them have more impact on military veterans than the standard civilian general population. We all know that the history of an early big win kind of leads to false expectations of future wins, and that's kind of a risk factor as well, the belief that, oh, I won big this time, I can win big again. Cognitive distortions, the way that people believe about gambling. I don't know if you know somebody in your life who is a bingo player, and if you've ever seen a photograph or a video of a bingo hall, you see the little troll dolls in front of them, and they rub their little troll heads before the balls stop spinning, things like that. That's an errant belief. That's a cognitive distortion that will bring them luck in order to win. I can't tell you how many times I had people tell me that they have their own system, that their system works, it's foolproof, and it's going to win for me. It's not going to win for anybody else because it's my system, that kind of thing. And these are very intelligent people, high functioning people who have these cognitive distortions, but that's a challenge. A recent loss, self-esteem tied to gambling wins or losses. History of risk-taking or impulsivity is also a risk factor. And I want to focus on veterans with that regard, because veterans in general have a higher prevalence of risk-taking behaviors than the general population. So this is a risk factor for gambling disorder that's maybe a little more intense for military veterans. Trauma history is also a risk factor for anybody with gambling disorder, and certainly trauma and PTSD have a higher prevalence in the military and in our veteran population. Family history of gambling. Yep, that exists in greater numbers in the military population and veteran population as well. And substance abuse, right? And again, higher prevalence rates in the veteran population than in the general population. The bad news there is that one study in 2018 showed that the veterans with gambling disorder, less than 5% sought treatment. So less than 5% of military veterans who qualify for a diagnosis of gambling disorder ever seek treatment. We're going to circle back around to that in a second. Was anybody trying to say something? Okay, I thought I heard somebody. Sorry. All right. So problem gambling among U.S. veterans. 2.2% of screened veterans tested positive for at-risk pathological gambling in 2017. About 4.2% of Iraq, Afghanistan veterans exhibited problem gambling. So almost twice as much. So this is something that we're noticing, is that it depends on the tour of duty. If veterans were in a combat arena while they were active duty, the combat arena kind of informs their propensity for gambling disorder as well. So Iraq, Afghanistan vets have a higher rate of gambling disorder than just the general veteran population. And maybe about 11% of mental health treatment seeking veterans reported a lifelong history of gambling disorder. That's out of Madison, Wisconsin's VA. And 40% of veteran gamblers seeking treatment reported a previous suicide attempt, which is why we're here today. So to talk about this connection. And remember my comment a minute ago that only 5% of treatment seeking veterans ever, of people with gambling disorder, veterans with gambling disorder ever seek treatment. So of the 5% of veterans, 40% of that 5% stated that they've had suicide attempts. We suspect that the prevalence of suicide attempts in the veteran population related to gambling is much higher because we don't see veterans in treatment as often as we should or as much as we should. The great majority of veterans with gambling disorder or qualify for a diagnosis of gambling disorder out there don't come in for treatment. So screening will help us bring that population into our treatment clinics here in New York. And that's what the goal of this coalition is one of the goals is to increase awareness of the issue and to increase awareness of screening for the issue so that we can bring these veterans into treatment. So rates of suicide, let's talk about that real quick.
Dr. Wade,
Again, oh yeah, go ahead.
I'm sorry, I didn't mean to cut you off. Thank you for the statistics. I just wanted to take the opportunity to introduce Dr. Toya as well. She's our guest speaker. She's going to provide her experience and
Yes.
vision when it comes to problem gambling among the veteran population. And if I could ask Allison Lamar from the New York Harbor VA to introduce Dr. Toya.
You're muted, Alan. Oh, there you go.
Good. Good morning, everyone. I'm Allison Lamar. I am from the Brooklyn VA, and it's my pleasure to introduce Dr. Toya. Dr. Toya is a clinical psychologist and have worked in the VA for nearly 20 years, initially starting out as a clinician in the alcohol program in the Bronx VA, and eventually treating veterans in the PTSD program. She exited the VA for about 10 years to provide assessment and psychotherapy for patients in nursing home and rehab centers. She returned to the VA in 2010 and became the program coordinator for the homeless domiciliary in New Jersey. She was in that role for 10 years until coming to the VA New York Harbor to be the director of the residential programs at this facility. Dr. Toya has expertise in working with seniors, addiction to substances, PTSD, anxiety, and depression. Thank you.
Thank you very much, Allison. I apologize, Dr. Wade. I just wanted to get the introduction in between the transition of statistics and correlation to suicide. Thank you.
Sure. And welcome, Dr. Toya. It's good to see you again. All right. So let's talk about suicidality and addiction. And we're going to differentiate between substances and gambling disorder. Again, suicide in the past 20 years has risen 35% in the general population. And among those reported substances, alcohol and opioid use disorder are associated with the greatest risk of suicidal behavior. Alcohol is a 10 times greater risk of death by suicide. 22% of deaths by suicide have involved alcohol intoxication. Opiates, I think, are number 2 with 20% of suicide related deaths are opiate related as well. Marijuana is around 10%, cocaine is at 4.6%, and amphetamine is about 3.5%. So there's a correlation between substance use and suicidality. Now, these studies historically have focused only on chemical addiction and suicidality and not on behavioral or process addictions like gambling disorder, like internet gaming disorder, like hypersexuality, things like that. The interesting thing about the studies is that they have clearly identified 2 main processes that connect gambling disorder and suicide. And those are indebtedness and shame. This is important clinical information for us to know, because if we can, from a treatment perspective, address the shame and the indebtedness as a primary focus of treatment, that goes far to reduce the suicidal behavior of veterans who have gambling disorder as well. So that was a very important finding. About 50% of people in the general population diagnosed with gambling disorder have at least at one point endorsed suicidal ideation, and about 17 to 20% have attempted. Gambling disorder has the highest rate of suicidal ideation and attempted suicide of any addictive disorder. So with veterans, this can be a compound effect. As I mentioned a minute ago, veterans gamble at a rate 2 to 3 times higher than the general population. And about 8% of active duty service members endorse gambling problems. There's a 2% lifetime prevalence of gambling disorder in any VA facility around the country, and about 9% prevalence of gambling disorder in Vietnam era veterans. So not only is the arena of combat specific where the veterans served recently, but historically, Vietnam era veterans gamble at a much higher rate than our OEF, OIF era veterans, Operation Enduring Freedom and Operation Iraqi Freedom. And remember, 20% of the general population have, with gambling disorder, have attempted suicide. 44% of veterans in treatment for gambling disorder have reported suicide attempts. So 20% in the general population, 44% of veterans in treatment report suicide attempts. And again, that's only of the 5% who are showing up for treatment, right? So there's a great larger number of veterans out there that need help, that they're not seeking treatment, and we don't know where they are, that kind of thing. So this data kind of highlights the importance of screening veterans specifically. So why do we screen? There's no biological test for screening, right? So gambling disorder isn't something that you can see in a person when you meet them, right? You would have no idea that this is happening behind the scenes. There are no physical signs of gambling disorder. There's no DTs when they stop gambling, that kind of thing that we see in other substance-related addictions. Clinicians often don't recognize the symptoms and rarely screen for problem gambling. And if the client's not talking about it, if the veteran's not talking about their finances and where they're spending their money, and if we're not asking, they slip through the cracks. And if we don't ask, we're not going to get the right answer. About 85 to 90% of problem gamblers, again, don't seek treatment. And this can be for a variety of reasons. There's a lot of shame and guilt involved. There's denial that is very common. Ambivalence, they don't really just care one way or the other, or they do care and then they don't care. A lack of health insurance, believe it or not, for treatment is a problem. That's a barrier. And the lack of treatment available. So I want to speak on that for a quick second. I mentioned at the beginning that, or actually Jen did, that I was at the gambling treatment program at the Cleveland VA before I came to Albany Stratton. And when I was there, right before I left in 2019, I started a study and I took a look at, I contacted the 10 VA hospitals in the country who have the highest number of unique patients and the highest number of patient encounters for those patients. About 1 million patients across those 10 hospitals, about 21 million unique encounters for those patients. I contacted them, spoke with their programs for addiction treatment, and I asked them a whole bunch of questions, but the three I want to talk to you guys about. One of the questions I asked was, do you consider gambling treatment within your scope of practice, individually or your clinic? 89% said no. So 11% said yes. So the great majority of folks out there in the VA healthcare system treating people for addiction aren't really certified or qualified to treat gambling disorder. Very honest answer, honestly, not a surprise. Then the second question I asked was, does your program screen for gambling disorder? 11% said they didn't know, 33% said they didn't, and 56% said they did, which was surprising. I was very happy with that number, believe it or not. And then another question was, when a veteran comes into your program or comes to see you for help with gambling, what do you do? 22% said they treated them themselves. 33% said they refer to an outside agency. And 33% indicated treat them as normal in their chemical addiction treatment program. Kind of a square hole round peg kind of solution. And it's a best effort. I completely understand that. And I appreciate the willingness of VA employees to make a best effort in treatment, but it's a square hole round peg. People don't often fare very well in a chemical addiction treatment program when they're being treated for gambling disorder. So let's talk about screens and how we can screen. The differences. So there are brief screens out there. There are then diagnostic screens and then a full-blown diagnostic assessment. Pretty self-explanatory. A brief screen is just that. It's a quick hit, ask a few questions, and if a veteran pops positive on that screen, then we refer them for further evaluation using a full diagnostic screen or a full-blown clinical diagnostic assessment, which involves meeting with a clinician face-to-face and going into a lot more background history. So I want to touch base, talk about some of the more common brief screens that are out there and diagnostic screens that are out there. And what I'm going to do, the cool thing is OASAS here in New York, which is the Office of Addiction Services and Supports, in case you didn't know, has a list of what they consider approved screens for diagnostic interpretation and assessment. Let me go ahead and put this in the chat box real quick. Yep. So I've placed the link to what I'm going to talk about, these screens. I placed the link to OASIS website in the chat box if you'd like to take a look at that at your convenience later. But I'm going to touch base with some of the ones that they mentioned. The LIE-BET, LIE-BET tool to rule out problem gambling. That's the name of the screen. It's a mouthful. It's a 2-item questionnaire too that has been deemed valid and reliable for ruling out pathological gambling. So if the veteran answers yes, then further assessments indicated. That's all brief screens do, is just recommend further assessment or not. The NODS-CLIP, the National Opinion Research Center Diagnostic Screen for Gambling Disorders, Loss of Control, Lying, and Preoccupation. That is actually the name of the screen, and I do apologize. The NODS-CLIP is a 3-item screen, so the screen is shorter than the name of the screen, and it's derived from an original screen produced years ago. NODS also has another one out there for relationships. The brief biosocial gambling screen, the BBGS, is the one we use here at the Albany Stratton VA Medical Center in our intake screens for many of our different programs, our homeless program, our addiction treatment program, our PTSD program, our behavioral health program, all ask these questions. It's a 3-question screen. And again, any one positive answer yields further assessment, that's all. So those are the most common brief screens. Those are 4. The diagnostic screens, they get a little more complex. They're more than just a few questions, and they basically map to diagnostic criteria, either in what the DSM-5, which is the current Bible for mental health disorders here in the United States, or the ICD-11, which is the national or the international classification of disorders and diseases. That's what the rest of the world is using other than the United States. So the diagnostic screens actually map to diagnostic criteria. That's the major difference between a diagnostic screen and a brief screen. And the most recent version of the DSM-5 is the DSM-5, and the diagnostic screen that OASIS recommends using is the DSM-5 screen for pathological gambling. Very easy. 4 or more questions on that screen. If they pop positive, then that indicates a problem that may warrant treatment. There's the National Opinion Research Center, NORC screen. That's NODS again, and that's based on the DSM-5 criteria. So it's a diagnostic screen as well. And that one assesses for both lifetime and past year gambling issues. So it takes a more comprehensive longitudinal approach to the person's experience. The Southern Oaks gambling screen, this is a popular screen as well. This is one that we used at the gambling treatment program in Cleveland. We still use it here at the Albany Stratton VA Medical Center. And it's a lifetime survey. So it takes a look at behavior over the lifetime, 16 questions, and can determine whether or not someone falls into one of 3 categories: non-problem, problem gambler, or probable pathological gambling. Okay. There are a couple other flavors to the South Oaks gambling screen. One is for adolescents and one is in Spanish, which is helpful. And then the Problem Gambling Severity Index, that's another one that the gambling treatment program in Cleveland uses. And it's an abbreviated version of the Canadian Gambling Index, 9 items rather than 31. It's slightly smaller. And it's a self-assessment tool, or you can use it as part of your screening process in your clinic. And again, all of these can be found on the website that I've linked in, that I placed in the chat box for you. If you have any questions about that, let me know. Happy to talk to you about that. And I want to thank you for your time and attention and joining us today and all the wonderful work you're doing in the field. Much appreciated. And I want to open this up now for questions about anything that I've spoken about so far. Oh, and by the way, if you do have questions, my email is the very, I was first. I think my name is the very first one in the chat box, and that's my email address there. So feel free, if you have questions later, reach out. I'd be happy to answer them for you. Any questions or comments?
If you have any questions, feel free to unmute.
Or put them in the chat, either one.
Dr. Toyo, was there anything that you wanted to add on, discuss, share?
Well, actually, I had a question for Dr. Waite, which is, I was wondering if he was going to expand a little bit more on the treatment, the interventions for patients with gambling disorder. So
Right.
I wasn't sure if he was going to continue
Well,
that?
treatment options out there. So the primary course of treatment is cognitive behavioral therapy and a flavor thereof. There's also motivational enhancement therapies, motivational interviewing techniques, things like that. Those aren't really, that's not a discipline, that's a technique of therapy. But CBT is has been shown to be effective, most effective with people with gambling disorder. Specifically, so with behavioral addictions, for example, sex addiction, the CBT model, we focus on behavior changes, right? With cognitive behavioral therapy and problem gambling, we focus on the cognitive distortions of the CBT triad, the cognitive distortions that people have. I mentioned the troll dolls with bingo. With gambling disorder, I can't tell you how many people I've met who have these errant beliefs. And that's the primary focus of treatment, by the way, is focusing on how errant the beliefs are and changing them in a CBT format, in a CBT model. That's primary. There are 2 drugs out there that help with impulsivity. One is naltrexone, which is commonly used to treat other substance use disorders. And the other one is a name that I can't even pronounce. It's a glutamate blocker. I can't remember what the name of the chemical is because it's like 16 letters long. But there are 2 primary pharmaceuticals out there that are being used currently to treat the impulsivity associated with gambling disorder. So CBT therapy, psychopharmacal medication, and then community-based supports like Gamblers Anonymous. The gambling treatment program in Cleveland had a GA meeting right there in the hospital every week. It was fantastic. So we try to refer people to the community for non-therapeutic support as well. And those are the primary focuses. Foci.
Is there data on the success rate for people with gambling who undergo treatment?
There is data out there. I'll be happy to provide that to you. I suggest we do that out of band. That might be outside the scope of this presentation today, but I'd be happy to share that with you.
If I may just elaborate a little bit further on the resources, Dr. Waite mentioned the gambling treatment program in Cleveland, the Cleveland, Ohio VA, which many people aren't aware of. It is the oldest inpatient gambling specific treatment facility in the country. Set up by Dr. Heather Chapman, pioneer in the field. We also, at the New York Council on Problem Gambling, have problem gambling resource centers. We have 7 across the state of New York. Each county in the state is covered. Each problem gambling resource center has a clinical network staffed with licensed clinical social workers, licensed mental health counselors, licensed marriage and family therapists. So when a veteran or a family member of a veteran or a civilian reaches out for help, we can connect them with a clinician as close to their hometown as possible for that one-on-one therapy. Also, one thing that the Albany VA is doing, which I would love to see all VAs do, is they have outpatient groups for gambling specifically. So you have Dr. Waite, who can see individuals one-on-one. You have an outpatient group with Maureen Corbett, social worker at the Albany VA. And other VAs are starting to take notice and do the same because there has been an influx of veterans reaching out for help. I just wanted to mention those resources as well.
If I can, Jonathan, then since you brought it up, I want to dovetail off of what you just said. The Albany Stratton VA is, I'm very proud to say, we are spearheading a program that starts next Wednesday. As a matter of fact, this has been a couple of years in the making, and we're starting an intensive outpatient program, an IOP program. Our addiction recovery program at the VA is threefold. It's a residential program, an IOP program, and an outpatient program. I've developed an IOP track, intensive outpatient track, specifically for behavioral addictions like gambling disorder, like hypersexuality, like internet gaming disorder. And we're going to start treating those disorders uniquely and individually. It's going to be a separate IOP track alongside the chemical dependency IOP track. And so we're expanding. Maureen's been doing that support group for gambling disorder for over 10 years now. It's amazing. So she's been part of this process as well. And we're starting an intensive outpatient program treating gambling disorder and other behavioral addictions starting next week. No other VA hospital in the healthcare administration is doing this yet. So this is kind of neat.
Dr. Waite, can I ask a question? And if you did speak on this, I apologize. I'm struggling with an ear infection, so following you might be difficult. But if a program is offered, let's say at the Albany VA and the veteran is in the Bronx, is how is the veteran able to get the care at the Albany VA, or can they go to the Syracuse VA if the program is being offered there? Can you talk a little bit about how we refer veterans to other VAs if programs are offered? Can we share that with the community, please?
Certainly, and right now it's a work in progress, specifically with this IOP program that I talked about. And your example is a real world example. I've already received referrals for treatment from New York City, from the Bronx VA, and from Hudson Valley.
I asked that question not knowing that, just want to put that out there.
That's wonderful. And Syracuse, actually, the Syracuse VA sent a referral this past week that was referred to them from Dr. Chapman in Cleveland. So it's full circle. We're a very small community, the gambling treatment community in the VA healthcare system. But the process in its final form will be a consult in CPRS, just like for any kind of interagency service. So if the gambling treatment program in Cleveland, that's the only one, right, for residential care. So all the VA hospitals in the country have a link to that referral. Now, for somebody outside, what we would have them do is have them call me. My phone number is, did I put my phone number there? I don't think so. I'm going to put my phone number in the chat box. So for people who don't have access to CPRS to place a consult, just reach out to our program. And I'm going to put my phone number. I forgot my phone number. There it is, 626-5334. That's my phone number. If you have a patient, a veteran that is engaged in VA healthcare services or wants a new veteran, reach out to me and I'll help spearhead that process for that veteran and get them engaged in care here at the VA if they're interested in VA healthcare.
Thank you, Dr. Waite. One question, Dr. Waite, will the intensive outpatient be in-person, hybrid, virtual?
Yeah, right now it's going to be in person. We with the intention, it's a phased program, a phase rollout. So it's going to be in person initially. We might expand that to be hybrid at the very least. So we'll offer in person and over virtual connections for the same groups. But right now, starting next Wednesday, it'll only be in person.
Thank you. In the chat box, I put in a couple of links. A great new book that's just hit the market is Fall In. It's a story of Dave Yeager, good friend of mine, who's in recovery, Army veteran from problem gambling, and also his podcast. I put both of those links in the chat box, along with the link to our website at the New York Council. You can find our treatment center for trainings, and you can also find help there as well. Any other questions? Comments, solutions? All right, I'm going to reshare my screen real quick. I'd like to discuss the community engagement and partnership coordinators at the VA, if I may. If you haven't had the opportunity to meet the community engagement and partnership coordinator at your local VA, I would encourage you to do so. It's a great resource for the community. It bridges that gap between VA healthcare system and our local community partners. You can see on the screen, there's contact information for the community engagement and partnership coordinators across New York State. And if I may, I'd like to introduce Mary Plekas of the Finger Lakes, New York, covers the Canandaigua and Bath VAs, just to discuss call to action and some of the things that we as a coalition take part in. Yes,
Hello,
ma'am.
everybody. My name is Mary Plekas, and I am from the VA Finger Lakes Healthcare System out of the Bath VA campus. And yeah, I would like to start a conversation with everybody. Just curious, what people think or your thoughts on and information on what are some of the best practices that you are all doing within your community, whether it's through an agency or on your own in the community. Just kind of curious to know what people's thoughts are related to that.
Again, feel free to put it in the chat box or unmute and speak up. correct me if I'm wrong, I think the silence may mean that the people that are in the meeting today are looking to learn more. Which is great, right? We're here as a coalition to help facilitate the next step. We can do trainings on screenings. We can come in and discuss what the issue looks like with the population.
Jonathan, I had a question for Dr. Waite.
Yeah.
Dr. Waite, you had mentioned an article early on. I think I might have stumbled upon it myself, just trying to learn more, talking about indebtedness and shame. And I was just really curious, your thoughts on that particular article or study, and what's being done, to help someone who's struggling with both of those, indebtedness and shame.
Well, I think what we can do, I'm gonna sort of answer your first point, your first question about best practices first, and then I'll address your second question. Best practices, I think that one of the things most glaringly that I've discovered kind of touches on what I mentioned a few minutes ago. When I surveyed those 10 top VA hospitals and discovered that a lot of them were referring gambling disordered patients to a chemical addiction treatment program. That's not a best practice. I understand it's a best effort, as I mentioned before, and I do appreciate that. We're trying to treat veterans as best we can, but that's a misfire on our part, right? On the VA's part. So best practice would be to do something like develop either in-house a treatment program for behavioral addictions like gambling disorder, or to actually develop a Rolodex. I'm showing my age now. Develop a Rolodex of community resources that we might be able to refer people to. So that would be a best practice, in my opinion. That's just right off the cuff, something that I come up with an answer for. Now, regarding the study, I think that was Kraus, if I'm not mistaken. This was, no, I don't know. The author's not listed here. Here it is. Moriano, Verve Moriano and Jan Nikinen. I can't pronounce that name. 22. So the importance of understanding that shame and indebtedness are the number 1 and 2 factors that affect suicidal behavior in folks with gambling disorders is important for us as clinicians to know. The shame typically can be, and indebtedness we can't really address as well as shame from a psychologist point of view. Indebtedness is a hard fact of life. So what we need to do is help the veteran. When I was at the GTP in Cleveland, almost all of our veterans came through that program had some kind of involvement with the legal system while they were in our program. And that just doubles the shame. They're ashamed of their behavior. I had one woman discover that her husband took out a second mortgage on her house, and both the primary and secondary mortgages were late by several months because it was gambling. She found that out in a session with her husband and me. So that's problematic, right? So the indebtedness needs addressed as well, because it does affect not only the veteran, but the family dynamic, as just cited in the example I just gave. So shame, motivational interviewing and techniques and motivational enhancement techniques do well with shame. CBT also works with shame because it takes a look at thoughts, feelings, and behaviors and how they're related and how they affect each other. And shame is certainly a very strong emotion we see in folks with a gambling disorder. So what their beliefs are about themselves, the world, and others that feeds their shame, that's a focus of intervention in CBT therapy. What are you thinking that makes you feel ashamed? What do you think people think about you that makes you feel shame? That kind of thing. So again, we fall back to the CBT model, and it works quite well. CBT focuses on the cognitive distortions that I mentioned a few minutes ago, but it also focuses on the emotions, the very real emotions that people in treatment for gambling disorder are experiencing right there in the moment. So again, CBT, I can't emphasize enough how effective that treatment is. And it's all in how you use it as well. Like I said, CBT is consider CBT like a Swiss Army knife, and depending on what the person's presenting with, that's the tool that you pull out. So for gambling disorder, it's more of a cognitive approach. For sexuality-based disorders and pornography viewing, for example, behavioral interventions work best, but it's still part of the CBT model, right? Rather than focusing on a cognitive intervention, we focus on a behavioral intervention for hypersexuality. We focus on a cognitive intervention for problem gambling. So it's a multi-use tool, CBT is. I hope that answered your question. Did it?
Yes, she said yes.
All right, very good.
What are some other questions out there?
Hi,
So this-
Jonathan.
Hello?
Would you speak a little bit about the correlation of problem gambling and homelessness? I know Dr. Wade touched on the indebtedness part of it, but I do believe there is a strong correlation to homelessness as well.
You are indeed correct. There's some research out there by Dr. Stephen Shirk that states problem gambling behavior is the second strongest predictor to veteran homelessness. Second's only substance use disorder. It goes hand in hand. And again, it goes hand in hand with indebtedness. Dr. Wade, was there anything that you'd like to add to that, to the research or the statistic?
Not off the cuff, no. I think that your statistic that you cited there is a very sobering one, no pun intended. But there's a very strong correlation, and behind substance use, gambling disorder is number 2. And now again, think of the compound effect. So you got a veteran who is addicted to a substance and is also gambling. And the effect isn't 1 + 1 = 2. It's 1 + 1 = 4, 6, 8, 12. It compounds exponentially. The more factors, the more risk factors you throw in. So yeah, there's a direct correlation between homelessness and veterans with gambling disorder.
Can I just weigh in on the homelessness issue?
Yes, ma'am.
Having worked in homelessness for a long time, and this is not necessarily specific to gambling, but what I found in my experience, it was very, very important to have a conversation about money with veterans, which interestingly enough, many of the counselors were resistant to having these direct conversations. And sometimes veterans would even get reactive about it. Why do you need to know these things? What is that about? And it's like, we're trying to help you get out of homelessness. We need to know what your money is if you're seeking housing. And so we had to have very, very direct conversations about money, how it's being spent, what's going on with the money, is there debt, what's your value system around money, and what things are, how is your money being consumed? And so gambling is one. I also found veterans doing things like hoarding and supporting like storage units I mean, you can't imagine all of the ways money can be frittered and not used for basic necessities. And then it constantly digs, there's a hole, the veteran digs a hole for themselves. And so there is a lot of, there's a need, I think, at all levels, whenever you come across someone who is reaching out for help, to have a dialogue with them about their money and what they're doing with it.
Yeah. And don't take things for granted. I was working with a veteran that comes to mind at the GTP in Cleveland. He was from the West Coast, North Oregon area. And he was service connected for PTSD and he had a service connected disability that basically afforded him over $4,000 a month in compensation. And that's a lot of money. He was homeless, literally living under a bridge with a backpack at the height of his gambling disorder. He lost his home, he lost his son, he lost his marriage, and was making a lot of money. But on the first of the month, he'd get paid. And then by the second of the month, he'd be broke. And he would do things like sell his child's toys that he bought to fund his gambling. And he ended up losing his home and was living under a bridge. The guy made $4,000 a month and it was gone every month. So don't take for granted that just because somebody has an income, ask the question, where's it going? And if they might get defensive, but persist, please persist. It's only to help them, as you point out.
That's a great point, Dr. Wade. I would love to see some form of screening in the compensation and pension hearings. I know there's some questions on financial fitness, but nothing centered around gambling. I'd hate to see somebody get a lump sum of money or get money each month that is struggling with a gambling problem that doesn't have a fiduciary set up. Dr. Toy, you brought up a great point with money. It's definitely a difficult conversation to have. Do you have any tips for anybody on how to bridge that? Looks like you're muted.
There we go. These are difficult conversations, and you have to prepare yourself for the reaction. I think maintaining a neutral tone, a good level of eye contact, and trying to frame questions in a neutral way, not in an accusatory way. Like, why are you spending your money this way? You don't want to put someone on the defensive, and you want to be able to educate them, even giving them a little education before you ask the questions. So you might say, I'm going to ask you some sensitive questions. I mean, it's fascinating today. People are more willing to talk about their sexual practices than they are about their money. So it's kind of interesting how things have evolved, right? But there's a lot of secret stuff that goes around money. And, it is important for us to explore it. So having like a neutral stance, giving a little education to prepare them. I'm going to ask you some questions about how you spend money, how you use your money. And this is important for us to know because it helps us to understand what's going on in your life and how maybe different problems might be affecting your ability to, meet your responsibilities. And sometimes when you lay the groundwork that way, someone may be more forthcoming. But certainly, if someone is doing something like gambling or using their money for drugs, they might be guarded too, all the same. So you have to be prepared for that. And sometimes you might have a preliminary discussion. Maybe they'll only disclose so much, but you kind of remain a little persistent and listen. You listen for things that are kind of evidence that the patient or the veteran is not really using their money in their best interest. I try to frame things in treatment around the veteran's best interest. Not, we're here to play gotcha, we want to expose you, but we're here we are hoping for your success. We want your success. This is what we know helps to lead to success. We are asking you these questions in your best interest with the hope of using the information for your healing, for your recovery, for your progress, right? So I have found that when you come from that place, which is a sincere place, at least from me, when you come from that place, veterans they drop their guard. And they're a bit more willing to show their underbelly. Because that whole shame piece that Dr. Waite was talking about, I mean, this is not just specific to gambling. Shame is an undercurrent for so many problems that our veterans come to us for, and coming for help. I compliment them on their courage because I know it feels like this is a weakness that they need help. But I always try to frame it in terms of what courage it takes to ask for help. And so it is important to be sensitive to shame for gambling in particular, but most any problem that a veteran presents with, and sometimes even come with bravado, right? They are defended. That bravado is a way of protecting their esteem. So we have to try and, look around that and past that, not get caught up in that.
Thank you, Dr. Toya. Marco, I'm going to get to your question real quick, but just building off of what Dr. Toya had stated, I think that may make the conversation even more difficult is with pathological gambling. It leads people to think that they're just one win away from being able to get back on their feet. Dr. Waite, is there any way that we can help individuals kind of put that mirror in front of their face and identify these gambler fallacies?
Yeah, the actual therapeutic approach, the treatment approach is to basically use the Socratic method of treatment, which is a motivational enhancement technique as well, but to pull up alongside the veteran and bring them to a greater understanding about their behavior and their thinking about the way that they think about gambling and that behavior, that kind of thing. It's a learned approach, the Socratic method and motivational enhancement. And what we try to do is develop a discrepancy between what they believe their situation is and reality. So you don't believe that you have a problem with gambling. How late are you on your mortgage? Right? How late are you on your car payment? What was the reasoning for that? Do you believe? Where do you feel that problem is coming from? I noticed that you haven't really talked to your wife about your finances, and are you hesitant to do that? Is that a concern for you? What does your wife think about your behavior, about this, this kind of thing? And again, like Dr. Toya mentioned, in a very non-judgmental way. We're not pointing fingers and not trying to shame the veteran. That's the antithesis of what we're trying to do. Pull up alongside them, show compassion, show understanding, but at the same time, guide their awareness to show the discrepancy between what they believe their situation is and what's actually happening.
Thank you. Marco had a message in the chat. He works at the vet center where they often see veterans that may not be eligible for VA healthcare. Is there a statewide referral network to connect veterans who are looking for gambling assistance outside the VA? Absolutely, the New York Council on Problem Gambling. Are there any inpatient programs that are pro bono or grant funded? So the New York Council on Problem Gambling is funded through the New York State Office of Addiction Services and Supports. So what we do is when we have somebody call that reaches out for help, before we connect them with a clinician, we identify if they have insurance. If they don't, that's fine. If they do, but it's an insurance that that particular clinician that they're linked up with doesn't accept, that's okay too. Again, we're funded through OASIS. We live by no barriers to treatment. So we will cover the cost of treatment for individuals. One thing with gambling addiction is finances are typically dwindled, right? So absolutely 100%, the New York Council on Problem Gambling has a clinical network that is funded to assist individuals with treatment. Are there any other questions? If not, I'd like just to give time. I know I mentioned the community engagement and partnership coordinators, but I'm just wondering if there's anyone on the call that is a CEPC that would just like to discuss it even more. The position itself.
This is Amy. I'm the CEPC on Long Island, and I just kind of wanted to share, Mary's call to action. Just that I have a coalition down here on the island who identified that there really is a lack of information out there, and there's such a need to promote this addiction and what's happening in our communities. So we are venturing out on a project to hopefully get some of this education into our school systems and the ROTC programs. Because, it starts at such a young age. We just think it would be valuable information to put out there. So I just wanted to respond and let you know some of the efforts.
Thank you, Amy. We're coming up on the hour. We do have until 11:30, but next I'd just like to discuss the coalition that we do have forming statewide. Our next meeting will be October 18th. It'll be from 10 to 11:30, same time as this chat. And the way it will be designed is we will start the meeting with new business, discuss statewide initiatives, and then we'll break out into regions. We'll break out in breakout sessions by region. So we have Western New York, Finger Lakes, Northeast, Mid-Hudson, New York City, Long Island, and we'll discuss our communities and where we'll go from there and what our initiatives are. If you're interested in joining our coalition, checking it out, please feel free to email me. I'll put my email address in the chat box. I'll get the link to you. We're looking very forward to this initiative. And word on the street is a lot of great work is being done on not only the local, but the federal level and getting this issue recognized and putting some steps in place to treat it.
Jonathan, if I can just dovetail off something you mentioned earlier and what Amy just mentioned about awareness. We've had a couple questions pop up during this hour, I know, on topics that could be another discussion. So by all means, if there's anything educationally that you're not aware of, that you'd like more information on, that the coalition might be able to help you with, let us know. Put the topic in the chat box and we'll see what we can do about that, because we're all about educating. That's why we're here.
Jonathan, is it possible for you to put up again the CEPC slide? That way those who are present can see who the CEPC is in their area, just in case they had questions. And not, as Dr. Wade just mentioned, it doesn't, yes, we're all here today to talk about, the problems we're seeing with gambling and the veteran population. But as CEPCs, we do so much work within other areas, within the mental health field, within our communities. We work with also several different agencies. So know that the work that the CEPCs are doing within the VA is not just limited to this topic. So please, as Dr. Waite just said, if you're interested in just learning more about what we do, or maybe bringing forward a different effort, please reach out to us. That's what we're here for, is really to engage with our community and really, come together and support one another. So I just wanted to throw you all to have our information. And actually, we'll at the bottom of the slide, it says find your suicide prevention local resources. We'll put that link in the chat. If you don't know what VA covers your area, you can, we'll put a link in that allows you to search in where you're located, to identify what VA covers the area that you're in. Oh, there you go. Could you provide the link for find your suicide prevention local? We will do that now.
Thank you, Caitlin. That link should be in the chat. I'm sorry, I didn't cut you off, did I, Michelle?
No, Marco has another question though, Jonathan.
Yes. Quick follow-up. If a veteran who does not physically live in New York State, does OASIS have the ability to connect a veteran to other states' programs? I have contacts on the national level, and if there's a veteran from other states, we can absolutely 100% assist them in getting connected with the services in their state. But to answer the question, OASIS only funds the New York Council for New York Council residents. But no veteran's going to get turned away. If somebody called me from Alaska, I'm going to assist them getting connected with somebody from their state to move forward.
And Jonathan, I would just like to add that New York City has a problem gambling resource center that serves the 5 boroughs. I do believe I had seen someone, maybe Elsie, from that from that program.
Yes.
But we do have information services that covers the 5 boroughs of New York City.
Absolutely. And if you go to the chat box, the nyproblemgamblinghelp.org link, you click on that and that will bring you to a state map, and you click on the county you live in or the borough that you live in, it'll take you directly to that PGRC and their contact information. I did also want to mention, I did see Dave Yeager mentioned, he put a message in the chat box. Just want to remind everybody of his podcast and of his book. Those links are in the chat box. Dave, you put in the chat box about Pennsylvania and working with CEPCs. I don't want to put you on the spot, but is there anything that you'd like to share? You're a wealth of knowledge. I want to give you the time and space to do so if you'd like.
Yeah, no problem at all. Thanks. And again, I apologize that the lights are on here and I'm not set up the way I thought I would be. That's all right though. Yeah, through you actually, Jonathan, we were connected with Mary Plikas, and with the Council on Compulsive Gambling of Pennsylvania have begun a veterans suicide and problem gambling coalition in Potter and Tioga counties, which is now working its way outward. I'm getting contacts from other counties outside of there. Myself and Josh Ercole from the PA Council, and we're beginning to build coalitions here in PA based on the model that you guys have created there in New York. And it's really just opening up conversations to the point where we had on our last meeting, a woman from Pennsylvania who just was not aware of the severity of this issue and now is wanting to get more involved. So it's working. We're getting some ears to open. We're getting some people to say, wait, I did not think this was as big of an issue. And I want to tell you from my own standpoint and on behalf of us here in PA, thank you for what you're doing because you're setting the model for us to work from.
Thank you, Dave. I appreciate you. Are there any further questions? Any comments? Anything that anyone would like to add?
Jonathan, if I may, I just wanted to add that Jonathan and I are primarily within the 13 counties of the Syracuse VA catchment area. We're primarily working in the North Country in Jefferson, Lewis, and St. Lawrence counties. So with veteran suicide and problem gambling. So if anyone is interested in joining our coalition and wants to branch out into other counties within our catchment area, please feel free to reach out to Jonathan or myself. And we can definitely continue to spread this throughout our catchment area.
And in case you can't see, that's Caitlin Treadway. Her email is under the Syracuse, New York section on the slide.
Jonathan, this is Mary Plickus again.
Yes, ma'am.
What I just wanted to share just in general with the coalition work, I think it's been just a wonderful opportunity to be out, connecting in the community. And I hear repeatedly raising awareness. And I think that's a really important piece in all of this is just that raised awareness, sharing information, seeing what we can do as a group, within the coalition. So I just wanted to mention that.
Thank you.
Jonathan, if people have like questions of what they'd like to maybe see on the next meeting, or maybe learn more about, is it okay if they either put it in the chat or reach out like via email to you or?
Yeah, absolutely.
Yeah.
If there's something else that you'd like to learn more on, please put it in the chat. We still have a few minutes, and if you don't have the time, feel free to shoot an email to one of us.
Yeah, I know for our Capital Region coalition, we had a panel discussion of lived experience, and that was really wonderful. That was moderated by Dr. Waite, and it was fantastic. So it'd be nice to do that on a state level maybe. And then I know we looked at the screenings as well, which is very interesting. I mean, Dr. Waite, you described them so well. I had a beautiful picture in my mind today when you were talking about them, but like to see them up on the screen too is so helpful, because I think a lot of people, if you haven't been doing the screenings or the assessments, it's nice to like physically see them as well. So maybe we could even talk about doing that at one of the meetings.
That's a great idea, Jen. And one thing I'll mention is that link that Dr. Waite shared, that PDF file. If you click on the name of each screening tool, it'll bring you to an example of each. It's a great resource. I use it all the time, and I believe I got it from Dr. Waite a couple years ago. Thank you.
You're welcome. And by the way, that's not an exhaustive, comprehensive list. There are screens out there that some people choose to use that are not on that list. And certainly, to touch on Jen's comment a second ago, if we want to expand on this, there are many other screens out there related to gambling disorder, but focus on other areas of your life and how you're functioning in those areas that the gambling treatment program in Cleveland uses as well. But they're not specific to gambling disorder, but they're certainly relevant to gambling disorder. So I'll be happy to share those and discuss those at some future date if you'd like as well.
If it hasn't dawned on anyone yet, this is a big issue. I always say in my presentation, it's an issue that's been as old as the military, but there's a movement happening, right? And we're taking initiative and we're getting things done. And if you're not part of it, you're going to be behind the times. I hate to utilize the opiate epidemic as an analogy, but in my personal opinion, I feel like this is the next epidemic. Gambling is just taking off. Accessibility has increased exponentially. You can't keep up with the trends, and it's just the availability is there. So please join us on our coalition. If you aren't able to participate in the meetings, stay looped in. Be a champion in your own community for us. Let us know what we can do to assist you in spreading this awareness, creating outreach, and getting screening done. We believe in the analogy of problem gambling prevention is suicide prevention, especially with the veteran community. One more time, I'll ask for questions. I do see some things in the chat. The Dwyer Vet to Vet programs in New York and many New York State counties are also very connected to their local communities. Not sure if they are connected to the Oasis formally. No, but Marco, you're right. The Dwyer Vet to Vet programs, we're actually talking about them internally before this call. Phenomenal resources, all about suicide prevention, great partner to be with, very active in the communities. So thank you for sharing that. If there's nothing more, I'll give you, what do we see, 18 minutes of your time back. We appreciate your time. We appreciate you joining us on this call today. Thank you, Dr. Waite. Thank you, Dr. Toya. Plethora of knowledge. It's a privilege to have you on board. Thank you. All righty. I hope everyone has a great weekend. Thank you very much.
Have a good day, everybody.
Take care, everyone.
Thank you.